Hi, hello everyone, and welcome to Geneva. Welcome to those of you who are online. And thanks for joining us here in person. So I'm David Sinclair, the Chief Executive of the International Longevity Centre in the UK. The ILC in the UK is one of 16, so we have 16 ILCs across the world, including one in Singapore and one in Canada. We've also got one in the US, and we've got Linda Fried here from Columbia University, who many of you will know, who I might throw the microphone in front of later on. So it's great to have so many representatives in the audience around of the different ILCs, particularly because we're here to launch our new Healthy Aging and Prevention Index. And of course, the context, as you know, is that people are living longer, but not necessarily better and healthier lives. And despite this clear consensus that prevention is better than cure and that there are real strong economic benefits of investing in health, there's still a really significant challenge around how we convince policymakers to deliver sort of on prevention interest. And it's great again to sort of have the minister from Canada here, I should say, and I will give you a sneak preview. Canada and Singapore both do very well on the index. But one of the interesting things about Canada, of course, is Canada is one of the few countries that spends 6% of its health budget on prevention, and it seems to offer a return on that investment. And in the UK, we've been calling across the world for other governments to do the same. So what we want to do with this index was to sort of develop this online tool that anyone can use, and we'd encourage you to all use it, but where we start to track how we're improving and how the world is improving in terms of healthy aging and prevention over the years. And I'm going to probably just stop, because otherwise I will go on for quite a lot, and we've got much better and smarter speakers than myself. But I'll do. Thank you for all the speakers for attending, and thank you to the funders, our declaration of interest, Amgen, GSK, Hallmark Foundation, MSD, Pfizer and Sanofi for grants that have supported the production of this index. So for those of you joining online, there is a chat function where you can join and ask some questions in the Q&A. Please do post your comments on Twitter if you'd like, using the @ILC-UK hashtag. I'm going to immediately pass over to Professor Les Mayhew, who without whom we certainly wouldn't have got to where we were, but Les has sort of helped us get to a place with, and I think it's fair to say it was Les's idea. So Les, can I, idea or false? No. Professor Mayhew is going to kick us off. We'll talk a little bit about the context.
Hello, can you hear me? Okay. So welcome to you all, and thank you for coming to our launch today, which I hope you'll find very interesting. The ILC Global Health and Prevention Index is one that measures and ranks all countries on 6 different dimensions: lifespan, health span, work span, income, the environment, and happiness. The first 3 of these are fundamental measures of human progress and sustainability. Life expectancy is the best known of these, but adding health and work span creates a more complete picture over the life course, which is arguably what really matters. For example, it can show how a low health span can limit working lives, among other things, whilst the gap between health and lifespan is an important indicator of the stock of ill health in society. How is it different from other measures? Well, other frequently used global measures, like income per capita and life expectancy, tend to fall under the auspices of the organizations that produce them, like the World Bank or the World Health Organization. I think this, although we don't set out to reinvent their work, it's important to say that we build on their work in actual fact, but we also don't reinvent what they're doing, but what we do say is that if you just concentrate on the indicators that they're responsible for, it only tends to give one side of the story. Even something like the Human Development Index, which you've probably heard of, only uses life expectancy in education. So our first claim is that we're broader. We wanted to do something more holistic and transferable, which we could use in our work on prevention, but also closely related areas, including spending on curative health, as well as other outcomes, such as mortality by cause. How did it come about? Well, a couple of years ago, I developed a similar index, which was internal to the UK. In this case, we also expanded the scope to include these other dimensions that I mentioned, such as the environment and outcome measures, crucially, the concept of happiness. People seem to like it. So the Global Index is not a carbon copy of my original concept, but it's turning into something that seems to be very useful and easy to communicate, as Aaron, my colleague, will demonstrate shortly. For example, we're able to rank 121 countries in the world. We can sort the countries into geographical and economic and political groupings, such as the G7, OECD, or the African Union, and we can compare them with each other. So we can show both the diversity at a macro level as well as at a country level. We can show clearly how global ranking affects spending, for example, on immunization and prevention, in particular, the balance between spending on curative care versus preventative health. So by providing this consistent frame of reference, we can use it to compare countries and groupings on a range of other methods, not always health. I'll give some examples in a moment. And of course, finally, it's possible to update the index over time, which is what we're intending to do. The index is good, you'll see, at identifying low-ranked as well as high-ranked countries, such as Haiti, Lesotho, Zimbabwe, and Afghanistan. You know who they are. But there are 3 or 4 countries that we're simply not able to do because of missing data. They just don't produce the data. North Korea has been a good example of that. So consider a couple of examples concerning our prevention work. A comparison on spending on immunization and prevention across all countries based on their global ranking. We found that lower ranking countries spend a significantly higher percentage of their healthcare budgets. High-ranked countries spend a significantly higher percentage of their healthcare budgets on both immunization and prevention compared with curative care. However, higher-ranked countries in the top 20 spend several multiples more on prevention per capita than lower-ranked countries. The bottom 40 countries all experience what we call negative life expectancy. That is, their expectation of life is lower at birth than it is in the age interval 1 to 5. Differences can be large, in some cases a few years. Finally, the index is predictive of other things like obesity, tobacco consumption, deaths from non-communicable disease. Results frequently reveal gradients up or down, but also on occasion turning points as we look across all the countries. You may be wondering how happiness fits in. Well, happiness is a UN annual publication based on surveys and helps to complete the picture. For example, can people be happy if they're not rich is a good question. Lastly, in considering the index, I do advise you to look at the website, which contains all the results so far, as well as data in a very attractive way with links to several very interesting case studies. On that note, I will hand over to Aaron to show you the results.
While Aaron's coming to the stage, I think that the happiness, we've just come back from Japan, and one of the really interesting things, as you'll see in the index, is Japan generally does relatively well, as you would expect, but actually scores fairly poorly on happiness, which is the only self-rated one. So actually, we had some really interesting conversations in Japan and with Japanese people about actually why and how, and is it true? And I think what we want to do with this index is to use it not to be judgmental and say country X has done much better than country Y, but actually as a way of having conversations. So I know Aaron will perhaps talk about this, but for example, the issues around work are very, very fascinating in terms of what is the ideal number of years we should be working in our lives, because clearly Europe probably works too little, whereas certain countries individuals would probably work far, far too much in terms of their proportion of their life they spent working. So Aaron, let me pass over to you.
Thank you so much. And I'm really delighted to be here today and present on the Healthy Aging and Prevention Index. Could I have the next slide, please? So I would encourage everyone to go online and check our index, preventionindex.org. But essentially, this index ranks 121 countries on 6 healthy aging and prevention metrics. And my colleague Les did talk about a few of them, but I just wanted to recap these again for you. We have lifespan, which we've measured using life expectancy, health span, which we measure using healthy life expectancy, work span, which is essentially the number of years someone's expected to be in work between the ages of 15 and 65. We have environmental performance, which ranks countries on a scale of 0 to 100. And then we also have happiness, which ranks countries on a scale of 0 to 10. 0 to 4 are deemed suffering, 5 to 7 struggling, and 8 to 10 thriving. So without going too much into the methods, essentially, these metrics, we've chosen these because we believe these are fundamental to us understanding how far on a path a country is in investing in healthy aging and investing in interventions such as prevention that can support people to live not just longer, but healthier lives as well. So what you see in front of you is actually just a picture of the index. Of course, on the website, you can actually interact with it, but you can look at each metric along with the global rank. You can look at each metric and see how the picture sort of shifts. But if I can get someone to click next. As you go over the map, you'll get these little black boxes that pop up. Obviously, here we can see Switzerland is #1. When you click on that, then you go onto a country profile, and it tells you a little bit about that country, including the political and economic blocks that it belongs to. And this is something that we've done and we've included into the indexes. We're not just ranking countries, but we're also ranking political and economic blocks as another way to demand action on preventative health. As you can see on the sort of top, right at the top, you can also learn more about our prevention program. This is actually a culmination of 4 years of work. So a lot has gone into it in terms of really demonstrating that there's not only a health, but an economic case for investing in preventative health, but also identifying how we can actually reorient healthcare systems away from cure, but focusing on preventative health. And now, of course, we've come to the launch of our index, which is really about how do we have these important conversations, both at the national, regional, and global level about what it is that governments can be doing to better support their population. Next slide, please. So these are the top 50 countries on the index. Sorry, I could not fit all 121, even though I really wanted to. As you can see, Switzerland is #1 here, and we have China ranked at 50. Of the top 20 countries on this index, only a third are non-EU, and that includes countries like Singapore and Canada. What you'll also notice is some countries are given a same numbered rank. This is essentially, for each country, we generate a country score. So if that country has the same country score as another one, they're also ranked the same on that global index. But there's lots to unpack here. So I wanted to maybe go into it a little bit. So next slide, please. So essentially what we can see is, and we can expect really to see inequality. This is an index after all, so there are going to be countries that do better than others. But I think what was quite surprising to us was how stark those inequalities are. And what we can see here is essentially the top 10 countries account for only just over 1% of the world's population. So we can arguably say that it's only 1% of the world population that's really best adapted to longevity. So we still have a huge way to go. Even when we look at the top 50 countries, so the slide I just presented on previously, that only accounts for just over a quarter of the total population. So again, we're talking about a small number of people who are benefiting from good health, wealth, and societal conditions. Next slide, please. Great. So if we take a little bit of a closer dive into looking at these metrics, we see that these inequalities persist. So for things like lifespan, when we look at the lifespan metric, there's a 24-year gap in between the countries at the top and the bottom of the index. We also see a 21-year gap in health span between the top 10 and the bottom 10 countries on the index. And then again, for work span, there's a 23-year gap between the top and the bottom. So this is something that sort of is visible at all levels. And of course, I and this is, something that comes up a lot in our conversations with people, is when we look within countries, is of course inequalities within countries as well. So this is something that is clearly visible both at global, regional, but then also at the local, national and local level. Next slide, please. Great. So as I mentioned previously, our index also ranks political and economic groups. And as you can see here, Scandinavia, G7, and the EU are the top performers. But of course, your eye probably goes straight to the work span of the European Union. It is currently in the last place for that metric for political and economic groups. And of course, there's a lot to be said around the skills shortages that the region is currently facing. And this could, to some extent explain what is going on. Shorter work span is something that we certainly have to be looking at closely in that region. Next slide, please. Great. So what's really powerful about the index is we can compare it against what we're calling secondary metrics, things that really matter to us. And of course, we've done quite a bit of analysis in this space, so I'm only going to share some of the key findings here. And I think Les touched on this point already, but what we can actually see, it's very clear that countries that perform better on the index also spend more on preventative health. So spending in prevention can result in better performance on the index. And this is a really strong message that we need to be getting out to all global leaders and health policy makers, that prevention actually does have a wider impact on society. And I think it's really striking. Obviously, we can see that Canada and the US are outliers in this space. And of course, there's lots that can be said about this. And David already mentioned that Canada does spend quite a bit of its health budget on prevention. And we've actually seen greater increases in life expectancy in Canada than we have in the US between 2000 and 2019, which can somewhat be explained by investment in preventative health. Next slide, please. So we also find that countries that spend more on preventative healthcare and immunization perform better on the index. So it's not just investment in prevention, it's also immunization spend. But I think also what's still striking to see is that investment in immunization still comprises a small proportion of total prevention spend. So this is something that we have to keep a close eye on, particularly taking into account that it's likely that a majority of that spend is going to be targeted towards childhood immunization and not immunization across the life course. And that's certainly something that we have to be looking not only in countries that perform well on the index, but actually throughout all the 121 countries featured on here. Next slide, please. Great. So this is probably one of my most interesting stats, I think, personally for me. So what we find is actually countries that invest in universal health coverage do also perform better on the index. But it's important to note that we've actually made huge gains between 2000 and 2019. We've actually seen a 40% increase in universal health coverage, with the biggest improvements coming from lower ranked countries. So countries ranked between 91 and 100. So the majority of these countries are from the African continent. They've seen 102.8% increase over this time. So this is something that we should seriously be celebrating. But at the end of the day, unfortunately, we're still seeing inequalities here, and there's still about a 40% gap between the top and the bottom of the index when it comes to universal health coverage. Next slide, please. Great. So what we see here is essentially that countries that rank at the bottom half of the index have 4 times worse access to qualified medical doctors than those that rank on the top half. Those that rank at the top half of the index. So when we're looking at countries ranked between 1 and 10, we're looking at about 40 doctors per 10,000 population. This goes down to only 5 doctors per 10,000 population for countries ranked 70 or lower. So just to give you an idea in terms of proportion-wise, that's 12% of the global population that has access, better access, and it's 42% of the population that has much worse access. So again, we're seeing inequalities where a few people are benefiting from better access to healthcare, whereas many more people are struggling to be able to access vital preventative health interventions that they need. Next slide, please. Great. So I just want to end on a final point, talk a little bit about, what our plans are for the future. And again, David and Les have touched upon this point. So alongside our Healthy Aging and Prevention Index is our Healthy Aging and Prevention Coalition. This is essentially a group of stakeholders, advocates in global health, so sort of at the forefront of this in discussion, coming together under a united vision to essentially call for action and demand action by governments on prevention. And we've just launched the coalition last week, I believe. We're looking to expand this coalition. We're looking to call for action throughout the next couple of years. So if anyone is interested in joining, please do find me later on. We can have a longer discussion about it. But the aim of this coalition is really to be able to have those conversations with global leaders on really important topics. And we also want to be widening what it is that we're looking at on the index. We want to measure over time to see which countries are progressing and which countries where there's still work that needs to be done. And we also want to do more analysis. So actually the sky's the limit a little bit with this index. We can compare it not just relating it to health policy, but we could look at pensions, for instance, if that's something that we want to have a look and see how that impacts on the other metrics on our index. And we also want to include more countries as well as data becomes available. Of course, we are, a little bit committed to what there is out there. So, I think looking into the future, we would certainly want to see how we can kind of use data in a more useful way to really present sort of the messages that we're trying to put out there, which is essentially around how can we get countries to invest more in prevention and how can we demonstrate that there is a very clear case for investing in preventative health. Thank you very much.
Thank you very much, Aaron. And just so you know, as you tell, we're really excited about the potential of this index, and we'll come back as well. On the point of inequality, some of you will know, so Alex Kalash, who used to be head of health and aging here at the WHO, now leads ILC Brazil. When Alex was born, I think he says life expectancy in Brazil was in your 50s. Alex is now, I don't want to embarrass him, but Alex is in his 70s now. So it's clear, and you've seen very significant changes over that time. But actually, equally within Brazil, you see very different picture if you live in Copacabana than you do if you live in the favela a few miles down the road. So really significant countries, even where you've seen very big growth in average life expectancy. This point, I'm going to pass on to our first of our keynote speakers, who is the Singaporean Health Minister, Ong Ye Kung, who's going to talk a bit about Singapore, I hope. And I should say we have an ILC in Singapore as well, led by Mary Ann Sao, who runs a foundation over in Singapore and very involved in health. Minister, please.
Mr. David Sinclair, Excellency, distinguished guests, ladies and gentlemen, I have not scrutinized the construct of your index, but I like what I hear so far, not because of Singapore's high rank, but I heard vividly that you were measuring health outcomes, happiness and other outcomes, and then correlated to input such as how much you spend, and then what is the doctor per population ratio. And I think I applaud that method. Because there are so many people, politicians included, who measure the quality of health by the inputs, which is, I think, will be quite wrong-headed. So thank you very much for such a robust, sensible index. And I'm pleased to join you for the global launch of this Healthy Aging and Preventive Index. It is quite clear in my mind, looking at the list, that this is not an index for competition. I think there's a reason why amongst the top few countries ranked high, they're all small countries. Contexts are different. In a small, especially in our urban environment, there is just more levers we can do to shape good health outcomes, as opposed to a huge country like Brazil or China, or Nigeria, where it's just a lot more challenging when you have rural areas. So this is really for self-evaluation and improvement. No country has a monopoly of good ideas and good policy programs. So the index can provide us with this platform to benchmark best practices, engage in good discussion on ways to enhance and preserve the health of our people. So we know from research findings that more than half, in fact, about 60% of health are socially determined. They are not determined in the hospitals. They are determined in homes and in communities. But yet most countries in the world focus on sick care and not health care. I am truly a minister for sickness, not minister for health. So even though we proclaim that we are all running healthcare institutions, our focus has always been on sick care. So today I'll explain why the anomaly, why I think the situation is changing, what governments need to do to further increase the momentum of this change, and what specifically it means for healthcare in the context of Singapore. So first, why the anomaly? I think the main reason is that sick care is clear and present, a constant drumbeat and pressure for authorities to respond immediately. On the other hand, the effects of healthcare, especially in shaping social determinants, that's long-term. You don't do it now and expect results immediately. It happens much later. So political pressures often force us to focus on the short term, while the important things with no immediate results fall prey to inertia and procrastination. We can understand from a personal point of view, right? The cake is so delicious, you'll eat it first and worry about the health effects later. Good things is always for later. It therefore follows that the best governance system to enhance health and the well-being of people are the ones that can forestall the short-term political pressures and do what is right for the people for the long term. And that, I think, in the final analysis, will be the benefit and value of this index, and point governments and add some pressure, some comparative pressure to do the right thing for the long term. But I think the situation is changing. Why? I'm optimistic because for governments to focus on social determinants of the well-being or the health of the people, and I think there's increasing pressure for governments to do that. I do not think in the nature of things, healthcare will overtake sick care in terms of urgency and emphasis, but I believe the two are gradually ranking equal in importance in the near future. The reason for this change is that the world is aging rapidly, which makes healthcare a clear and present problem too. The phenomenon that has already taken root in many parts of Europe and Northeast Asia will now spread to the US, other parts of Europe, and certainly Asia. For example, it took Singapore only 19 years to transit from an aging society where 7% of our population are 65 and above to an aged society where 14% of our population are aged 65 and above. And it will take us only another 9 years, that is 2026, to become a super aged society where 21% of our population is aged 65 and above. In all these countries, people could see the escalation of disease burden on families and on healthcare workers. In hospitals, the workload is rising, sometimes crushing. There is recognition that there is little point of us just keep on mopping up the wet floor when the sink is constantly overflowing with water. At some point, you have to stop mopping and also try to turn down the tap. And that is the problem all our hospitals are facing. That means to reduce the prevalence of severe diseases by focusing on preventive care, and then to generate health in homes and in communities. Next question. So what do we need to do? The effort required is not long-term. It's not just long-term, but also holistic. Education is key because it gives persons skills, knowledge, agency to do something about your life, to feel useful, to be more wholesome, and to have the ability to contribute and live life with purpose and dignity. And that is especially important for seniors. And these are all prerequisites for good health. In Singapore, our education system is known to be of good quality, with a strong emphasis on numeracy, literacy, and values, but also it is stressful and competitive. The latter is not necessarily unhealthy, but it needs to be calibrated with the changing aspirations and traits of each new generation. Living conditions, physical living conditions, it matters a great deal. In Singapore, over 80% of our population, we live in subsidized public housing, which is of high quality by international standards. Beyond a roof over a family's head, our public housing provides a sense of security, of ownership, a safe haven for children to grow up. Over the years, public housing designs have also moved with the times. They often look more like condos these days, and in keeping up with rising aspirations. In addition, we equip our housing estates with public libraries, sports facilities, parks and gardens, common spaces, eating places, so on and so forth. All these are not counted in the expenditure on preventive care, but actually they contribute a great deal to preventive care. Beyond the hardware, we also encourage volunteerism and help social organizations proliferate their services. These efforts help develop supportive communities conducive for healthy living. Another third important social determinant is employment. Fortunately, Singapore has a vibrant economy with many opportunities for people young and old. Our labor force participation rate is high for both men as well as for women. We are gradually raising our retirement age so that there's a right for people to work longer should they want to, and our retirement age is not linked to the age for withdrawing your retirement savings. There is, of course, the very important aspect of law and order and good security. We have entrenched the concept of neighborhood policing, and we take a no-nonsense approach towards crime. And so Singapore becomes one of the safest places in the world, which I think also contributes a great deal to health. So perhaps the area that needs the most work on is healthcare. And I think we are not alone in this world. Unlike sick care, which happens in hospitals and clinics, healthcare needs to happen in communities and homes. Now, COVID is a major wake-up call to health authorities on the importance of preventive care to strengthen social determination of health. For the simple reason, during COVID, when someone needs to turn up at the hospital, you are already in trouble because that's curative. In the end, the best measures during COVID are all preventive in nature. Wearing your mask, observing hygiene, taking your vaccinations. The Singapore healthcare system post-COVID is therefore undergoing a major transformation. We are building up not just one healthcare system, but 3 healthcare systems. First, the acute care system, comprising hospitals and clinics, that's well developed, but it needs to expand in capacity. The second is the preventive care system. This is, I would say, in its teenage years, not mature yet, and so it needs to be developed. And after many months of planning, we will be rolling out our national healthcare program called Healthier SG. There's a national preventive care program, and this will be happening in July 2023. Preventive care will be developed through our primary care system of family doctors who will serve as the foundation level of healthcare. Healthier SG will comprise all the key components of preventive care implemented in many parts of the world. We rope in private GPs into the national system. We leverage dedicated patient-doctor relationships. We have a national enrollment process. We have individualized health plans. We have community support to make social prescription possible. We are fully funding preventive care, such as vaccinations, as well as health screening. And we have something special, which is in Singapore, if you take minimum of 5,000 steps a day, the government actually give you incentives and you get shopping vouchers. Some people use it to buy soda, which is not recommended. The third system, and I think this is only in its infancy, is the aged care system. Nursing homes and aged care facilities, they are always necessary, but they cannot be the mainstream and the default arrangement for the aged. We are building up social support to enable majority of our seniors to actively age in communities. Our family units are getting smaller, and our seniors are increasingly at risk of becoming isolated. I'm always reminded of the research results that for an isolated senior, the detriment to their health, the effect on their health is equivalent to smoking 15 cigarettes a day. So get out and make friends, get out and exercise. So we therefore need to vigorously combat the challenge of deteriorating health due to social isolation. Building up a community-based aged care system requires tremendous social activation of volunteers, of organizations. We are establishing a network of several hundred active aging centers and to serve as focal points for such social interventions. And there are also physical premises for seniors to form social groupings. The advancement of age and the demographic march, this is inexorable. It is irreversible. But aging and the deterioration of health is not necessarily a given. With good policies and improvement of our care systems, we can slow down aging and even reverse frailty in many instances. And if we can preserve and enhance health, 65 need not be that magic number where we somehow are regarded as aged and we fall on the wrong side of the dependency ratio. Our mission is to raise that magic number 65, 70, and then to 75. And we can be healthy and continue to contribute to society and take care of others way beyond age 65. We can narrow the distance between our healthy lifespan and our biological lifespan, and we can redefine aging. Singapore is committed to making this challenging but important transformation of our healthcare system into 3 systems I mentioned earlier. As other countries confront their own demographic challenges, they will also need to undertake similar journeys. An index like this is a very useful tool at this time of history, and it serves as a compass for governments to track our progress for preventive health and aging, to monitor and evaluate if we are indeed achieving our outcomes. So congratulations, thank you, and all the best.
Thank you very much, Minister. And I think your focus on prevention is certainly music to our ears. I think one of the other things that hopefully our index will do over time as well is allow us, for example, to look at some of the rapid aging countries, look at Hong Kong, Singapore, Korea, and look at how they're changing relative to other countries, but also looking at countries that are aging before they get rich, you know, what the impact of that will be in terms of people's position on the index. Thank you so much. I'd like to now pass over to the Honourable Carolyn Bennett. Thank you so much for joining us, Minister for Mental Health and Addictions and Associate Minister of Health for Canada. And again, we have an ILC in Canada. There's something about having an ILC and scoring highly on their index. We should do some work on that. Carolyn, would you like to take the podium? Thank you for joining us today.
Well, thank you so much to the ILC and Mr. Sinclair and to the Minister for your inspiring remarks, but to all the researchers and all the hard work that's been taken and all of you that have come this afternoon, in that this is indeed exciting, and that I think, as the Minister said, this is about outcomes, and that we, I think, as governments realize boasting about how much we're spending on something isn't actually important if we're not getting the outcomes. And I think that's what populations now want to know, what happened with these investments. And so it's great for me to be here with our ambassador from Canada, Leslie Norton, as well as the wonderful Dr. Teresa Tam, our Chief Public Health Officer, and Heather Jeffrey, the new president of the Public Health Agency of Canada, all of whom are very focused on equity, and why, when we talk about equity, then it means data matters, that we have to have the disaggregated data to know who's doing well, who's not doing well, and where the investments have to be made. I remember being here a number of years ago, probably with Alexander Kaleche, and when I was the seniors critic, and started my presentation about maybe in Canada, we always question, how come in our Indigenous communities, they're called elders, but in the non-Indigenous communities, they're called elderly. And I think that what we learned during COVID was that where elders are respected, they did very well in the first wave of COVID because their communities protected them. The young people didn't want their elders to get sick. And so that there was this piece around respect and dignity that was very much protective, I think, in terms of prevention, as the minister said. I think we also, in Canada, benefit from the teachings of the medicine wheel, where really from life cycle, that keeping people well, mentally, physically, emotionally, spiritually, trying to find that balance in your life is actually what is about health, not health care. And that we actually do think that the sickness care model or running a repair shop was a sort of colonial import that we could do without, in that if we would listen to the people who really, from even the idea that getting sick is a bad idea. And as we heard, turning the tap off before the floor's wet is really, as the minister said, is what we have to do. If we're going to have a sustainable health care system, then we have to decrease the demand side. And so it is, I think, hugely important that what ILC is doing, and Professor Mayhew and Iran, the only one I want to question is the pursuit of happiness, in that I think that that sometimes is an unattainable goal. And what the Indigenous people in Canada have taught us, that if you switch that to gratitude, and start the day with your Thanksgiving prayer, or that somehow you end up not really worrying about what everybody else has, but are grateful for what you have in your life. And often that's relationships and meaningful work. So I think it's so exciting that, this index brings together health, wealth, societal metrics, but also helping countries decide where to make their investments, where to do health promotion, disease prevention for older adults, and understand that these investments in the social determinants of health actually is consistent with really what all of us, and particularly ILC and Alexander Kaleche, when he was here at the WHO and Active Aging, that this is actually what it is about supporting healthy aging. I think we remember when 20 years ago, everybody is worried about the gray tsunami that was going to drown our healthcare systems. And I think that isn't happening, because the older persons have never been healthier. They stopped smoking, they're exercising, they're doing what they need. And we have to deal with the isolation piece hugely importantly, I think, as we learned the hard way through COVID. So even though the ministers reminded us that we're not to be competitive, I don't want Canada number 11 anymore. I want to be in the top 10. But I think it is that collaborative model that you've described, where we're all able to learn from one another in wise and promising practices. What are the people who are higher up in your index doing that we could steal those good ideas from anywhere? And I think that we're happy to be there, but I think that we all know that then we've got to do more. And I think that, the United Nations Decade of Healthy Aging will put a focus on this so that we can actually once again really look to one another and encourage us all to be able to invest in healthy aging. And I think, as we say, that human rights don't have a best before date, that this is about how do we make the investments to enhance and maintain older adults' physical, social, and mental health, as well as independence in workforce and community participation, as well as quality of life. We think that this has to be based on the best available research and public health surveillance. We know we've got to get better data. I think in Canada, we realize we've had decent data in hospitals. Dr. Tam has decent data in public health. We have Stats Canada that, you know, will get us the data, but not exactly in real time. But we need better community data. And I think our family docs and everybody are saying that we're just beginning to understand even what to measure, what should be the indicators of community, and how do we move on those kinds of, I think what Dr. Tam and all of us, what are the indicators around the social determinants of health? How do we move forward, and how do we invest properly in those preventive, in disease prevention and health promotion? Canada is complicated, as you know, and I think there's been many times that we sort of curse the federal system, where we actually have to say, well, if only this province would do more, and how do we incent provinces and territories to actually make the investments? And I think what we're trying to do in Canada now with the bilateral agreements is to incent that everybody should have a family doctor, that the health human resources need to be supported and not burning out, in that is not good for our older people, older persons. What are we doing in the investments in mental health and substance use? And how are we using the tools across Canada to be able to get the rural parts of Canada the best possible care, as well as, I think, the kind of digital care where we're now understanding care as care, particularly in mental health supports, and how do we get people what they need wherever they live. It is this now you know, double pandemic, triple pandemic, which has had this disproportionate effect on certain groups, older persons, young people, this idea of mental health, substance use, gender-based violence, that these have all come at the same time, and yet we have to deal with all of them in terms of what is our response and our recovery. And I think that as the minister said, that isolation has been hugely problematic, devastating, particularly in long-term care, where family members, like, I thought family members used to be able to be trained to go if somebody was in the infectious disease unit. I don't know how some of these lockdowns happened, where people were just by themselves, without being fed, without being toileted. That this was, I think, heartbreaking for us to watch. I think that as we have learned that where the elders were valued and protected, or when the elders said in our country, let's get out on the land, let's get the young people out on the land, and that's a place where we don't have to be isolated. We can go out and be with in terms of the land and the water, and be healthy in a healthy environment. And we're very grateful to the elders and to the leadership that was so much part of us, nothing about us without us, of them saying, no, what we need is money to go out on the land. We don't want our people to get sick. And so it is, I think, the reality of whether it's smoking, obesity, physical inactivity, this isolation piece is actually heartbreaking. And during the pandemic, we were able to add a little bit of funding for the mental health. We started a website called Wellness Together Canada, where people could go and explore what the resources were there. We were able to fund some distress centers, but it was interesting on mental health that the stigma in certain communities was much greater. And it was the young people that came to us to say, you don't understand the stigma of talking about mental health in my community. And whether that was the South Asian community, whether it was the Black community, that is the young people pushing their parents and their grandparents to be able to talk about mental health and describe their emotions, and how important that is to be able to seek help when you need it. it is a how we have to be moving to the mental health needs of older adults, as we say, have to build these more integrated approaches to health, mental health, and long-term service. We can't have these silos anymore. We can't have primary care over here, hospitals over here, long-term care, public health, without those systems talking to one another. And I think that we are really trying to improve in Canada in that sort of bottom-up regional way. Has been said, the living long enough and dementia, I think, has been very devastating to people. And I remember being with the Lona Kickbush at the World Demographic Association, where there was this amazing Japanese researcher who had these functional MRI images where if people were sitting watching TV, their brain shut down. If they were singing, it lit up. If they were cooking, it lit up. And so I think that we actually know what works and what doesn't work. And I think anybody who heard the Royal Melbourne Scrub Choir at the opening, that we know that worked for the healthcare workers, as well as I'm sure any of the patients that were nearby. We have released the first National Dementia Strategy in June 2019. It is the 3 objectives of prevent dementia, advance therapies, and find a cure, but also improve the quality of life of people living with dementia and dementia caregivers. The kinds of apps that are now being designed at Baycrest, where people can stay home at least 1 or 2 years longer, when they get these prompts, as is the door locked, is the oven off, that there are ways that we can use technology to help people stay independent much longer. And we are trying to invest in these kinds of innovative community-based projects, but also the awareness, surveillance, and guidance. It is that I think dementia is something that just scares everybody. And I think there's huge motivation for us to be able to move forward on the research, because people just want to know what they can do to prevent it. And I think that, as Dr. Kalachi had said, that in terms of age-friendly cities, that it was about listening to seniors as to what they needed to be able to get out of the house. That if you have a seniors-led approach, you'll find that what they really want are shade trees, park benches, and public toilets. That it is what it takes to get outside, but it's not necessarily what the caregivers would have chosen. But you have to, I think in Canada, we have a say, nothing about us without us. That actually has to be serious when we're dealing with older persons. And so it is, when the WHO started with the age-friendly model in 2005, and I have to admit, the first time I was pretty embarrassed that New York and London all had it, and we didn't in Toronto, we didn't in lots of our cities. And so we went home and tried to push. But one of the things that's been really fun, innovative in Toronto, in my riding, are things called naturally occurring retirement communities. That as soon as an apartment building has more than 50% or 60% seniors, it means that they get the same kinds of supports and services that a purpose-built seniors residents would have. It means they are entitled to public health, they're entitled to Meals on Wheels, they're entitled to all these things in one setting. And it was this 90-year-old who moved from Kingston to Toronto, who just with her pester power was able to find out who owned the building she lives in, and then ask us as the city councillor and me as her member of parliament to actually make sure that they got the community kitchen, the community space, and all of the things, and that the owner of the building had to respond to the fact that this had now been designated a NORC. So I just think that as we go forward, we are going to have to know that being independent is important, but preventing falls is important, that no newspapers on the floor, rubber-soled shoes, that this is no scatter rugs. There's just things that we can teach that keep people independent. And my dad died 48 hours after breaking his hip. I don't want that to happen to anybody. And it was heartbreaking. And so we know that we have to keep people safe. And in Calgary, there's this place called the Kirby Center, the first ever elder abuse hostel, which was built to think that they were going to get people out of the garage that the kids had put away or whatever. What they found was women at 65, when they qualified for their old age pension, arrived at the Kirby Center with their first check that had ever been in their name, and they saved for their first and last month's rent till they could be independent. And so it really was Freedom 65 for those people. So we just have so much to do. I think when we think of the new Rainbow Wing at the Rec-I Center in Toronto, where older persons don't have to go back into the closet in order to go into residential care, that the 2S LGBTQIA plus people deserve to be able to preserve their identity in aging. And so I'm really proud of what's happening bottom up in terms of innovation. It is so exciting. And so I do think that we have broken down the myth of the great tsunami. We now know that we want to be elders, not elderly, when we grow up. And I just want to say that I can't thank you enough for the ILC and for us to develop the new index and just keep at us, because data saves lives. And as our ambassador to the UN, Bob Ray, says, stay curious.
Right. Thank you very much. Thank you, and I'm conscious you need to go for a flight. And thank you both. No, and just say, great that you say want to have impact. The next stop for us is India, where we want to talk about this index in India in the summer. So perhaps the ministers will join us in India alongside health ministers to talk about actually how, the conversations we've had with the Indian government has been, look, we want to improve. We see where we are at the table at the moment. We want to get better. So really, really great to have that attitude. We've got 3 sort of responses, and I am conscious you may need to leave. If you do, please do, but we're running slightly behind. I'm going to pass to Julia and Mario, but is Linda still here? Do we still have Linda? Yeah, Linda, can I just ask if we have a couple of minutes from Linda, if we could pass the microphone over to Linda? Do we have one there? So Linda is from Columbia. All right, thank you. Thank you so much. Thank you. So Linda is from Columbia University and hosts the International Longevity Center in the US. So I just want to give Linda a couple of minutes to, thank you very much, to say a few words.
Thank you, David. I wasn't prepared to make comments, but I'll give you a quick reaction, and I'm honored to do that. I would say that what you're presenting is very exciting. And it points out that there's huge cause for optimism. If countries are, if there's this huge range between health span and lifespan across countries, it means there is huge opportunity to close that gap. And what we have, I think there are strong evidence that we need to think about several things. One is how we add to primary care and medical care that is focused on creating healthy longevity, a new kind of public health system delivering population health across the whole life course to prevent the development of disease and disability, and to deliver the conditions that enable people to choose healthy lifestyle, create equity in the opportunity for health. That has to be, I think, added to the primary care focus. And the other thing is, Minister Ong was saying, which is I think the recognition that the costs of inaction are very, very, very high. And part of what we leave on the table, aside from obvious economic costs, are not benefiting from the unprecedented, highly valuable social capital that older people bring, which we've never had in the world before. And whether that's delivered in ways that bring not just meaning and purpose, but impact through volunteerism or through caregiving or through working longer in one's life if one wants or need to, all of those will bring huge benefits. Well, thank you for the opportunity.
No, and thank you for joining us, Linda. Thank you. We've got a few minutes each for so Julia from the World Medical Association. Julia, and we've only got, I think, 3 minutes, so sorry, maybe 3.5. So Julia.
Thank you very much. I wanted to give just some brief thoughts and aspects what we physicians think when we talk about how to improve healthy aging and prevention. Just as a background, I'm from the World Medical Association. We are the international representing body of all physicians, and our mission is to ensure the independence of physicians, act on behalf of patients. Oh, if you change the slide, sorry. Act on behalf of patients and physicians, foster highest possible standards of medical ethics and best medical practice. Next slide, please. So we have heard here a lot about this healthy aging population, but I would like to emphasize here, we have two aspects of the society. One, which is a healthy one, where the prevention and healthy living and that they stay independent is our focus. But we have as well the other part of the society where long-term care, palliative care, and an ethical way of living the end of the life is important. Another aspect I would like to highlight here is what often the society is not realizing, that especially the healthy aging population has a value for us. They have an economical power. They're in many countries, especially in the developed countries, and they have a human and social resource for us. Is it by taking care of kids, bringing something back to the society? So there is a value for the society to really keep them healthy. Next slide, please. When we talk about this healthy aging, I think we need to take into account as well that for the developed world versus the developing world, the aspects, what we have to do and how we have to do it is quite different. And in general, the society is getting more elder. But on the other hand, we have an increased burden of chronic diseases, non-communicable diseases in the whole society, where for everyone, and especially for the elder generation, prevention, health promotion is very important. And the health system would need to put a focus on this one. Next slide, please. But not only the society is aging, the health workforce is aging as well. So we have already now an estimate of a shortage of 18 million health workers by 2030. But if the health workforce is aging too, more are retired, the whole shortage will increase. And prevention, health promotion, focusing on staying healthy would need quite a lot of more health professionals, health workers, community health workers, social workers. It's a big economical area which needs to grow. Next slide, please. So prevention should be embedded in a life course approach and through a multi-stakeholder approach. That means, is it from creating age-friendly environments to aligning the health system to the need of the elder population? And we talked as well, I think that Singapore had a very interesting aspect of how they shaped the health system into 3 gradients. So prevention, health promotions must be embedded in primary health care. it's important that it's mentioned in universal healthcare, that it's part of this one. Otherwise, the health system would not be reimburse it. It would be not covered, and it can't be out of pocket. Otherwise, we have again the social and educational gradient of how to access, to be aware about prevention health promotions. Due to time, I just skip to the next slide. So as I said, the healthcare system would need to change as well. And from the historical curative health system to a rather preventative one. So, but in the aspect how Singapore had it, it's not either or, it's working together, and there's a finance of the health system is important. In many systems, we have the health system quite separated from the social system, from a strategy, from a finance point of view. But if we talk about prevention, healthy aging, I think they need to link more together. And I think they, again, the Singapore approach is a very interesting one. And I would like to know more from the minister about it, but I will follow up with him. The workforce needs to be prepared for this. The education would need to change into this one. And next slide, please. So finally, it's an inability of the society and governments to adapt effectively to population aging, not aging itself, that is likely to have the greatest impact on socioeconomic development. And most of the health conditions of older age can be prevented or delayed. Thank you very much.
Great. Thank you very much. And Julia, and the final contribution from Mario Otsligio from the European Global Coalition on Aging. Mario.
Thank you, David. Thank you, ILC, for having us. My name is Mario Otsligio. I represent today the Global Coalition on Aging. It's a very difficult situation for me because I'm Italian, so we speak very fast. But I think it's good now, right? Yeah. So for whom doesn't know, the GCOA, the Coalition on Aging, is we say the leading business voice on aging-related policy. We really represent, we are a network of company thinking and acting differently with a lot of positive spirit around healthy and active aging, really advocating for solutions that are practical, that are highlighting how much aging can lay a path for economic development, for social well-being, but also for business, sustainable business growth. So you have heard, I'm sure, a lot of time what I'm about to say, which for the first time in history, we're having a situation where there are more old than young people. And remarkably, a child born today can actually reasonably expect to live up to 100 years old. But whether this expectation can actually become a reality really hinges on the health, social, and economic policies of the countries where in which they live. And that was actually the point also the ministers were trying to make before. Now, Minister Kung said something, I think, very critical, that in order to meet the needs of this changing demographic, really there is this need of this paradigm shift from the 20th century model in healthcare, where we look into acute care and treatment, to a different model. We say 21st century model, where preventing and predicting disease is actually key. And we have the tools to do that with growing digital health, for instance, but also with growing health literacy and information explosion, if you want. So the future of our health system really relies on laying this path for the people to remain healthy and functioning well at all ages. That's also a concept that it's critical in the decade of healthy aging and all the WHO positioning on that. And I think that index that has been that is being launched today really underscores that countries that invest in preventative care, so we can talk about checkups, we can mention screenings, they really come out high in terms of longer lives and healthier lives. And I liked also the point that the minister from Canada was doing. It's no surprise that happiness is also positively correlated. I think I liked actually the gratitude concept expressed in there. So one thing I wanted to mention today that maybe is complementary to what everybody else has talked about is really around life course immunization, and in particular adult vaccination. We have seen that those represent a viable example of a wise investment that should be a top priority for governments. We could even be bold and say, thanks to childhood immunization, we're actually here enjoying this, potentially enjoying today's mega trend of aging. We have seen, we have witnessed a lot of scientific advances. We know that vaccine can prevent illness from influenza, of course, and the linkages with cardiovascular disease, with stroke, to pneumococcal pneumonia, to shingles, and very soon to RSV. So there is some interesting vertical, I think, to look into when we talk about prevention. And of course, the COVID experience in the worst possible way, but has taught us a lesson that we understand now the importance of keeping the population healthy, of keeping the hospitals running, but also the economy overall healthy. So there are opportunities when it comes to policies that collectively will lead to more adults accessing vaccines. And as the countries, hopefully there will be more editions of the index, as the countries are really looking and improving their rankings, I think that's really an area where they can start focusing, meaning, choosing the right policies, from supporting innovation, of course, but bringing vaccine to the people in need, bringing vaccine and immunizations in national health strategies, designing policies also to ensure that caregiver can get vaccinated. And that's all conversation there. But it also meaning deepening conversations on expanding the number of people across the health ecosystem who could actually administer those vaccines, and also the type of places where people can access those technologies. Of course, that's only one aspect. There is much more, and that's been highlighted before. Cognitive function, injury prevention, but also looking at the social and economic aspects, ensuring emotional well-being, and of course, maintaining engagement and planning for social security. It's a complex, but it's of course, and I know that very well because my country doesn't really score too well on those indicators. It is an opportunity. It is an opportunity to seize upon some pragmatic policies to really make significant progress as we approach. We are at the midpoint, so as we approach the end of the Sustainable Development Goal agenda. Thank you for having me, and congratulations on the index once again.
Thank you very much. And very, very grateful for all of you. 3 final points for me as we close. Thank you for all speakers. Thank you for those of you who've joined us in the room and online. In terms of the myth of the tsunami, the over 50s across the G20 spend 54 pence in the pound on the high speed. They earn 1/3 of all money they spend, 1/3 of, and they do 1/3 of the work. And of course, their volunteering value is equivalent to what the EU and Turkey spends on defense. So huge contribution. We have, of course, a U-shaped curve with happiness. So we are happiest when we are younger and when we are older. So perhaps in the future with an older population, we're going to be happier. It's a good positive message. And then finally, again, a big thank you to Hallmark Foundation, Amgen, GSK, Pfizer, Sanofi, and MSD for their support. Next year, we'll want to explore how things have changed over the last few years since COVID. So I hope you will join us all there. And for those of you in the room, we have a opportunity for some networking downstairs. So we want your ideas on what you want us to be thinking about for next year. So thank you all very much for joining us, and hope to continue talking downstairs. Thank you. Thanks.